Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. It's Lindsay Smith-Rogers. What will happen to the incredible progress that has been made around the world in HIV/AIDS prevention and treatment since the 1980s? Today, Stephanie Desmond talks to Dr. Chris Beyrer, past president of the International AIDS Society, about who is impacted when prevention is halted and treatment is paused, and what the future of HIV prevention everywhere looks like after massive cuts to the President's Emergency Plan for AIDS Relief, also known as PEPFAR. Let's listen.
Chris Beyrer, thanks so much for joining me.
Wonderful to be with you again, Stephanie.
Your most recent piece in the Lancet is subtitled Ongoing Backwards. Could you unpack that for me?
So, the largest commitment to a single disease in history was the program begun by George W. Bush in 2003 called PEPFAR, the President's Emergency Plan for AIDS Relief. And PEPFAR was an extraordinary commitment to really try and bring antiviral therapy for HIV infection to the great majority of people in the world living with HIV, who were, of course, mostly in sub-Saharan Africa. And until then, we had effective therapy, but really there was almost no access for the great majority of people in low and middle income countries. And all of that changed with an extraordinary $15 billion commitment over 5 years that was renewed repeatedly under consecutive administrations, including the first Trump administration. And the program was an extraordinary success. It saved an estimated 25 million lives. It prevented perhaps 5 million perinatal infections, which is such a devastating condition to begin life born with HIV infection. And at the time of the inauguration, so that's January 20th, 2025, of the second Trump term, there were about 21 million people worldwide supported by PEPFAR on antiviral therapy. About 600,000 of them were children and adolescents. And PEPFAR was the single biggest funder of prevention. It was funding 91% of all PrEP starts, pre-exposure prophylaxis starts worldwide. And that had really picked up in 2023 and 2024, which were the two best years ever for prevention. And then, of course, what happened was the announcement from the White House of an immediate cessation of all foreign assistance. That meant, of course, PEPFAR, but also USAID, the Agency for International Development, the President's Malaria Initiative, which was the largest single initiative for malaria, and, of course, support for vaccines for children and adults, childhood vaccines, and maternal child health programs. All of these were abruptly ceased. There was an outcry over PEPFAR because you cannot simply stop antiviral therapy for 21 million people. HIV is different than, for example, hypertension, because if you go off antiviral therapy, you have an interruption. First of all, you start to be symptomatic again. You also become infectious for your sex partners, so you ramp up the epidemic again. But also, for the individual patient, you run the risk of developing antiviral resistance. So when you do, if you can, get back on antivirals, there's no guarantee they'll work. You may need a next-line regimen, a second or a third-line regimen, much more expensive, harder to access. So this was seen immediately as a catastrophic decision. And there was tremendous pressure on Secretary Rubio. This is important to understand that PEPFAR, our contributions to the Global Fund to fight AIDS, TB, and malaria, USAID, and the President's Malaria Initiative are all under the Department of State. So it's the Secretary of State who makes this call. So Secretary Rubio, under intense pressure, immediately issued a waiver. It was 48 hours after the cessation of assistance. And in that waiver, it basically said we are prioritizing life-saving treatment and prevention of mother-to-child transmission. And all the prevention services were stopped until further notice, and the only people who could get PrEP were pregnant and lactating women who had a risk for HIV infection.
So that's quite a loss, right? All at the same time.
And it had, I think, several important features. One, it was so abrupt. Normally, when we look at a healthcare transition to country ownership, successful transitions typically take about 10 years. This was done over a 3-day weekend.
Yeah. Talk to me about this waiver, though. You said, there's a waiver, so that must mean the program started back up immediately. But I don't think that's the case.
Right. So the way the PEPFAR program worked is that PEPFAR essentially is a funder. It had 2 implementation arms. It was 60% of it was implemented by USAID, and the other 40% by Health and Human Services, principally through the CDC, Centers for Disease Control and Prevention. What happened in the event was, of course, before the PEPFAR waiver was even in place, USAID was being gutted. By the time the money started to flow again, AID had already lost almost all of its overseas staff. It had lost massive amounts of funding. And so the implementation of the program really couldn't be done. So the waiver actually meant very little. And we've seen that again and again, that the administration will put a pause on something, but in the meantime, the facts are changing on the ground. The money is going away. The people are being fired. So that when you say, okay, we're now going to return to services, you actually can't.
So how many people do we estimate are affected by this?
So we published, actually my new group at Duke with a modeling group at University of Washington, we published the first assessment of just what the 90-day pause would do in the next year. And that estimate was that there would be a minimum of 100,000 excess deaths and 135,000 excess perinatal transmissions. And that's because in sub-Saharan Africa, the majority of people living with HIV are women, and most of them are of reproductive age. So if you're a woman of reproductive age, you're pregnant or you're planning on having a baby, and you're HIV positive, you're living with HIV, if you are treated effectively, there's almost zero chance of transmission. We solved perinatal transmission with treatment. But if all of those women come off, you are going to see a huge increase. And we have recent data, it's not published yet, from an investigation we've been doing in Uganda that shows that at least in some of the clinics, we're back to, among HIV-infected pregnant women, 25% transmission. So back to where we were before antivirals, back to the 80s and the early 90s. And that's why my piece is called Ongoing Backwards, because we're going backwards on HIV, we're going backwards on malaria, we're going backwards on childhood immunization.
The progress that's been made in HIV is one of the most incredible accomplishments in science.
Totally.
And to think that, as you said, in a 3-day weekend, it's gone. This feels as though we could see a huge resurgence, not just in Africa, but in the United States as well, and other developed countries.
Well, that's one of the things I said in the piece. I said that the spring of 2025 may well be remembered as the beginning of the second wave of global AIDS. And for somebody who's been working on this problem for 33 years, and even longer if you count the years I was a medical student, that's just from when I finished my training at Hopkins. It's unbelievably painful and difficult to see this happening to the work of so many people. And it's an achievement of science, but it also was an achievement of global health equity. And it was an achievement of human solidarity, really people coming together, and of activism and advocacy. And the Congress doing the right thing, and the generosity of the American people. All of that has also been so threatened. And, I think at the most fundamental level, the fundamental idea behind health equity, global health, public health, what we all work on, is that all human lives are of equal value. And that, I think, is being called into question.
What does this tell the people? I mean, I'm sure that there are many grateful people in Africa that the United States has funded all this treatment over the years, the PrEP, mother-to-child transmission reduction. What is that telling the people of Africa?
Well, I tell you, people are terrified. Many have expressed, we have a number of programs running, so we have a lot of clients, patients, recipients. We're, and our teams are talking and trying to reach out. There are, for example, a number of NGOs that have just gone on a volunteer basis. People are continuing to try and serve and not paid, but that's not sustainable, of course. I think what we hear very consistently is that people think that there probably will be treatment coming back through their government programs, through their ministries of health, but they'll have to pay for it, and they may not be able to. And so there's a widespread belief that people are going to die, that they themselves are going to die. We have a program for HIV adolescents who are living with HIV in Tanzania. And we've been talking with those kids and the peer outreach workers who work with them. And it's very widespread belief that they had a chance at life and now it's going away and they're going to die. That's a terrible thing for an adolescent to have to deal with.
It's appalling. I mean, I'm having trouble almost absorbing what you're telling me because it just sounds like a complete collapse of something that was incredibly successful for so long.
Yeah. The prevention part of it is also a huge problem because we were not, before the inauguration, before all of this happened, we were not succeeding in bringing down the rate of new infections globally. The target for 2025 was that we were supposed to be down to under 500,000 infections a year globally. And in 2024, we were still over 1.3 million. So we were nowhere near getting control. Now, with prevention essentially halted and so many people losing access and again becoming infectious, we will undoubtedly see an increase in new infections. That's already been modeled by many groups. What that means is that if treatment ever does come back, there are ever more people who need treatment. So we're really going backwards on prevention as well. And that's an enormous challenge because once you ramp up an infectious disease again, it is ever harder to get control. The same is true of malaria. We were not on a good trajectory with malaria because of climate change. And because there are new mosquito vectors, heat-tolerant mosquitoes from India moving into Africa, and we were losing malaria control before all of this. Now, the entire President's Malaria Initiative has been ceased. That was USAID, 100%, not 60% like PEPFAR, 100% implemented through USAID. It is effectively stopped, and that means nobody's getting bed nets. Nobody's getting indoor insecticide spraying. Nobody's getting the malaria treatment through that program. They may be getting it through government programs. And the rainy season is coming. So we expect to see a tremendous increase in malaria transmission and death. Now, most of the people who die of malaria are either pregnant women or children under 5. That is hard to live with. Part of what I wrote about in the Lancet piece is also just trying to personalize it and make it real for people. The traumatic experience, which came back to me in just a flood of vivid memory of taking care of all of these babies when I was a medical student in Brooklyn who were dying of AIDS when it was untreatable. Of course, we had no antivirals, and they suffered terribly. And taking care of them was enormously painful. And, you think you're not carrying that around with you, but you are. And when you're confronted with something like 135,000 new HIV infections in newborns that we could have prevented and now are going to happen, the trauma comes back super vividly. And I just know that anybody who shared that experience, who took care of people living with HIV and AIDS patients in the 80s and 90s before therapy, is going through something very similar. I've never had an article, honestly, that has had such a response. I have heard from people all over the world, from a former Hopkins advisee of mine in China. Thank you for writing this. It's gone to President and Mrs. Bush, I'm happy to say. And because this was, of course, one of the great legacies of his presidency.
You have painted a very bleak picture. Are there any glimmers of hope moving forward?
There are several, I think, important points to be positive about. One is there are a number of countries who are going to be able to pick up a lot of this. South Africa is a good example, Botswana, Rwanda. There already were a few. All the countries were contributing some of this. So I think it's going to be a mixed picture. There are, unfortunately, some large, lower-income countries. Think about Ethiopia, Democratic Republic of Congo, who are not going to be able to cover these costs on their own, at least not for the foreseeable future. So we'll see a mixed picture. We're hopeful about the Global Fund replenishment that supports AIDS, TB, and malaria. That's coming up in the fall after the U.S. budget. And we have had donors in the past, like Canada, step up and help. And so we're looking very carefully at the European Union, at the Germans, the French, the Canadians. And there are countries that could do more, but just haven't. So, for example, the Gulf states, Saudi Arabia, they have not put anything really into the Global Fund, and they certainly could. We're also looking at foundations. Obviously, the big ones that have been in this space is the Gates Foundation, but there have been many others. The Dutch had stopped funding in this area. They're coming back to support the LGBTQ programs because that's a part of their foreign policy commitment and their human rights commitment. And they're not a huge donor, but they are helping in those areas. And then I have to say that we underestimate our African colleagues and friends. They are incredibly resilient. And the communities are really working hard to support each other. And I think they're going to have to put pressure on their governments to do more. And we're going to see that. I also think, it's important to say PEPFAR, the Global Fund, the malaria programs, USAID, was always thought of as a part of American soft power. That we've given away. And the level of mistrust now is just extraordinary. And people feel betrayed. They're right to feel betrayed. They also, I think, there's a lot of sentiment that governments should not have put themselves in this position where something as fundamental as providing the basics of HIV treatment and prevention of mother-to-child transmission is funded by an outside donor. That is a huge vulnerability. And now we're seeing what that means.
Chris Beyrer, thank you so much for this very informative conversation.
Thanks, Stephanie. I'm sorry. I know it's a lot to take in, but it's also, I think, really important that people understand these policy changes are affecting millions of human lives.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Cesiri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.